The first physiology lecture for this week that I'm going to begin with would be the electrical conduction of the heart muscle. Now, if you take in 215, you probably already have a good idea about muscle contraction and the electrical impulse mechanism of either skeletal muscle, neurons, maybe even both. So for those of you who have not had 215 yet, or maybe need a refresh, I'm going to go over that in summary here. So a couple terms that you need to recall, and if you need a refresh on contraction, electrical activity of muscles, 10.3 is a good reference section to maybe read through as an extra reading. So when we talk about the membrane potential, we are talking about the charge inside the cell. So we have this plasma membrane, we have a charge inside the cell, we have a charge outside the cell. And that membrane potential is the charge inside the cell. At resting, it's inactive. So no ions are causing too much of a change in electrical charge and net charge to cause anything to happen yet. Now, ions are constantly moving across the plasma membrane, even at rest. And when they get to certain concentrations, that is when we start to depolarize. And depolarization is just the change from a negative to a more positive charge across a membrane. And when that reaches such a level of a certain positivity, now we have reached what's called threshold. And threshold is kind of that level at which after that, everything just escalates and goes in a positive direction. It's kind of like positive feedback. Now, once we reach threshold, something has to continue to an end point in order to reset itself. And once we reach threshold, then an action potential is generated, and that is driven by a rapid change in membrane potential, first in the positive direction, and then it'll come back down into the negative direction again, and that's called repolarization. So resetting that inside negative charge and outside positive charge. Repolarization usually happens a little extra, and so that's called hyperpolarization, and then things will start to balance out to the resting membrane potential again, with a little bit of a refractory period, just meaning that neurons and muscle cells can only be stimulated in such a way that they need this resting period in order to reset completely before they can be stimulated again. So we're going to go over this in more detail. So at resting potential, and we're going to use a neuron as an example here from 215. At resting potential, sodium is greater outside the cell and potassium and negatively charged proteins are greater inside the cell. So here's what I'm going to do. I'm going to suggest that you draw these out as well here. And I'm just going to draw out what this looks like at the different stages. So at resting, okay, we have a plasma membrane. So this is my plasma membrane here, and we have sodium outside the cell, and we have potassium inside the cell. Okay, now we have more sodium molecules outside the cell than we have potassium inside the cell, meaning that the out net charge of the outside of the cell is positive and the net charge inside the cell is more negative. And we're just going to call these negatively charged proteins. Those are inside the cell because remember that proteins can't leave the cell membrane usually. So they're too large. Okay, so here is what resting potential looks like. So we say that the outside of the cell is more positively charged, the inside of the cell is more negatively charged. And there are channels in this membrane that sodium and potassium are going to move between. Okay, so if we say that sodium concentration is higher outside the cell than inside the cell, sodium is going to move from an area of high to low concentration. And so naturally, sodium is going to want to move into the cell. Okay, same with potassium, and that's just down their concentration gradient, right? That's just what we've been talking about in terms of facilitated diffusion. Potassium is higher inside the cell than it is outside the cell, and so potassium is going to naturally want to move out of the cell. Now, this is happening all the time. Sodium is trying to move in, potassium is trying to move out to balance that sodium. We have mechanisms called sodium potassium pumps that are constantly moving those ions back against their concentration gradient. So if the sodium does make it into the cell, this pump is actually going to pump it against its gradient and put it back out here. Remember, that's active transport, using energy to move something against its concentration gradient. Now, why is that important? Because as these sodium molecules move in and these potassium molecules move out, once it reaches a certain point of an imbalance on either side of the membrane, that's when things start to happen. So at resting potential for a neuron, this will be measured as about 70 millivolts inside the cell here. Okay. Now, an action potential is generated when so much sodium moves in and so much potassium moves out. So at threshold, okay, let's say that now we have had the movement of sodium inside the cell. We still have some potassium left in here, but we have a lot of sodium that's moved in. Okay. And then we still have some sodium out here, but we have a lot of potassium that's moved out here now. All right, so now what do the charges look like? Well, the inside of the cell has now become slightly positive because we have had all of these sodium ions move into the cell, and we've had some potassium ions move on the outside of the cell. Now, granted, something I want to make a point of is that both sodium and potassium are positively charged ions, but the movement here is that there are 3 sodium ions moving for every 2 potassium. And so there's always 1 extra positive charge entering the cell than there is leaving the cell. Okay, so that's how we get to this more positively charged inside compared to the outside. Now, granted, it's more positive, but it's still a negative number. Okay, actually threshold for neurons is negative 55. So that's still a negative value, but it's more positive than that negative 70. All right, so sodium is going to enter the cell, and then that's going to cause this membrane potential to become less negative. And then as it approaches this threshold, this negative 55, now we have depolarization happen. And what depolarization means is that we're going to have this huge influx of sodium into the cell now. So some sodium had already moved in just by passive diffusion, but now we're going to have this huge influx of sodium ions due to more of these channels opening. As that occurs, and this becomes so positive here, and notice here we have this depolarization going all the way up to a positive 30. Okay, so that's a lot of sodium moving into the cell to get us from a negative 55 to a positive 30. As that happens, now channels for potassium are going to open. And potassium is going to try and leave the cell at such a rate that it's going to balance out the influx of sodium. And as that happens, as more potassium leaves the cell, now we take this from a positive. Now we're going to get just a little bit more negative. And again, I say more negative, but it's still going to be in the positive range here during repolarization as we approach our resting potential. So as more positives leave, we become more negative. And that is called repolarization. That's that balancing of potassium to sodium inside, outside the cell. So now what do we have here? At depolarization, depolarization, now we've pretty much flip-flopped the ions, right? So usually sodium is found outside the cell and potassium is found inside the cell. Now we've switched those almost completely where sodium moves inside the cell and potassium is outside the cell at that 3:2 ratio. Now, more potassium leaves, it gets really excited. A lot of potassium leaves, in fact, too much leaves, because this membrane is very permeable to potassium ions. And that's just called hyperpolarization. So you see this repolarization here. Here's resting potential. And notice how we go just a little bit more negative than resting potential. That's just because too many of these actually left, and we need to bring it back to resting potential. It's just this very slight dip in a more negative direction of potassium ions. But eventually what will happen is those ions will rebalance themselves back to this resting potential of -70, and we will then reestablish that resting potential. And again, the sodium potassium pumps that are located in the plasma membrane kind of reset those. So sodium inside the cell will be pumped outside the cell, and potassium will be pumped back inside the cell against their concentration gradients, their normal concentration gradients. And then we go through this period of refractory. And as that pump is doing its job, this point of refractory is going on to where we cannot stimulate this neuron to fire again, or we cannot allow these ions to cross the membrane at such a rate that another action potential happens again until we have reset completely. That if you were to refire this neuron before we have completely reset everything, your next impulse won't be as strong, or your next muscle contraction won't be as strong. And in that case, then we would have something called fatigue. Okay. Now, when we talk about the heart, we're talking about muscle contraction based upon these charges. We're going to talk a lot about depolarization, repolarization, that kind of thing. Now, where this occurs in the heart is something called the SA node or sinoatrial node. I'll show you where this is at in a second. But basically, this is a group of cells inside the right atrium. And these are self-firing. So they don't need to be stimulated necessarily by the nervous system, although they can, but they are actually capable of reaching threshold on their own. And so then they can trigger the action potential independently of the nervous system. Now we're going to talk in a little bit about how the nervous system can adjust the firing speed of the SA node to accommodate higher and lower heart rate, but ultimately the SA node can self-fire. And we're going to talk about the rushing in of sodium, but when we talk about the heart, I just want you to be aware that calcium is also important. Calcium and sodium are usually found on the outside of the membrane in higher concentrations. And so those both will move inside the cell. We call the SA node the pacemaker of the heart, meaning that it can self-fire, so it can regulate and initiate heartbeats on its own. From the SA node, then the impulse will get transmitted to something called an AV node. And this is on the very bottom of the interatrial septum. So that split between the two atria at the very bottom of that, where we begin the interventricular septum. And that is where the impulse will travel to next. So the SA node is important for contracting the atria, and the AV node is now going to be the beginning of ventricular contraction. And the speed here, so the SA node fires at its own speed. The AV node, that impulse is going to be slowed down just a little bit because we need to fill those ventricles to their full volume. Remember that atria are smaller than ventricles, and so that SA node can fire no problem, at its own speed. But if the ventricles fired at that same speed as the SA node, then the complete volume that's in the ventricles would never get fully ejected because you have more volume in that area and more muscle tissue to fire. From that AV node, then we go into an AV bundle. And then Purkinje fibers come off of that, and these bundles are going to stimulate each of the ventricles. And I'll show you what this looks like in this picture. So here's the SA node up here. It is in the right atrium near the superior vena cava. Remember that that's just a specialized group of cells that is self-contractible, and that's going to depolarize. and cause an action potential to occur. So I always think of like an electrical shock almost. That shock is going to travel over to the other atrium and then eventually reach the AV node. Now, something that I really need you to understand is that when these chambers contract, the atria contract together and then the ventricles contract together. It's not the right side of the heart and left side of the heart. It's the atria together and then the ventricles together. So this SA node is going to fire and depolarize, and then that impulse is going to reach this AV node. Once depolarization happens of this SA node, that is going to cause the action potential to cause both atria to squeeze and contract together. Now, from the previous lecture, we know that once those atria contract, they are going to push their volume of blood through the AV valves here, the tricuspid and the bicuspid valve, and then fill up the ventricles. Once we're at the AV node here, now the impulse is going to slow down because I said that the volume of blood, these ventricles have to fill to completion so that the correct volume of blood is being pumped with every beat. And so this impulse is going to slow right here to allow these atria enough time to contract their entire contents into these ventricles and push that blood through. So at this AV node, then the impulse is going to slow a little bit. The AV bundle here splits into bundle branches. So we have a right bundle branch and we have a left bundle branch. And the point of these bundle branches is to contract a ventricle. Each are going to contract a ventricle. So this right bundle branch is going to come down here and kind of surround the right ventricle. The left bundle branch is going to come down and surround the left ventricle. And then we have these little projections coming off of those bundle branches called Purkinje fibers. And those are just going to transmit the impulse throughout the myocardium of the ventricular walls. Okay, so as those bundle branches and Purkinje fibers then reach threshold and generate an action potential, then both ventricles are going to squeeze in unison. Now, just to recall, where is the blood from the right ventricle going as this right ventricle squeezes? It's going to go up through the pulmonary valve into the pulmonary trunk and then out to the lungs. Okay. This left ventricle, when it squeezes, it reaches threshold, generates an action potential, and this myocardium squeezes. That's going to pump blood through the aortic valve into the aorta and then out throughout the body. So this is the electrical conductivity in relation to the pumping of blood through the heart. So again, this SA node, these terms we didn't really talk about, but essentially a syncytium is just a group of specialized cells that work in unison so that both atria can contract at the same time. And then these junctional fibers are just going to transmit that impulse from the SA node to the AV node. And then the AV node becomes the AV bundle, in which the left and right bundle branches come off and give rise to things called Purkinje fibers. And then the ventricles contract in unison. That's what ventricular syncytium would mean then, is that the ventricles are contracting in unison. So starts with the SA node, which is the pacemaker of the heart. It's self-firing, and then it's going to go to the AV node, to the AV bundle, to the bundle branches, to the Purkinje fibers. This can be measured using an EKG or ECG, or electrocardiogram. And the electrocardiogram records the electrical changes that are occurring across this plasma membrane as depolarization and repolarization occurs. So that's a way to measure that. And if you've ever had an EKG or been hooked up to a heart monitor before, or maybe you've hooked a patient up to a heart monitor, basically what they do is put electrodes on different areas of the skin, and then that's detecting electrical impulses of the heart. And it's denoted by several waves here. So here's a heartbeat here, here's a heartbeat here. The small wave before this large wave is called the P wave. We're going to go into what each of these mean in a second. But this first small wave is called the P wave. This big spiky complex is called the QRS complex. And then this T wave happens after that spike. Then we have kind of this flat line refractory. And then we'll have another P wave, a QRS, and then we'll have another T wave, and then we'll have a break, and then we'll have another P wave, and so on and so forth. And then we can also further go into these segments. So from the P wave to this Q point is the PQ segment. And then here's S to the T would be the ST segment. And when we get into these different segments or these distances between waves, that's going to become important in terms of like arrhythmias and things like that. Those are diagnosed off of abnormalities in these segments. All right, I know this looks like a lot, but we're going to take it slow here. So basically, we're just going to go through this again and what's happening in the heart and then what the EKG looks like. So from that SA node, we're going to fire, okay? And the depolarization is going to happen in the atria. Now, when we have a wave, that is indicating depolarization or repolarization in a chamber, or set of chambers rather, either the atria or the ventricles. So this P wave is denoted by depolarization in the atria. So again, what does depolarization look like? If we were to draw it out. Okay, if this was the plasma membrane of all of the atrial cells, and we were at resting, okay, this is resting. What does depolarization look like? Depolarization is when these sodium ions are going to move in. Okay, and then this plasma membrane inside is going to become more positive. So that's depolarization. So that's what's happening in the atria. Okay, during that P wave, that's what's being measured, is this electrical difference, this change from a negative to a positive. If we talk about anatomy in relation to the EKG, from the PQ segment here, so from P to Q, and that is how long it takes for the impulse to go from the SA node to the AV node. So that's traveling from here to here would be the PQ segment. The PR interval is denoted by the conduction through the AV node then. And remember that all this is happening so quickly, like there's about 0.8 seconds per heartbeat. That's why we say a normal heartbeat is like 60 to 70. And so from this PR interval here, we have the signal conduction through the AV node. Now, here's the depolarization happening of the P wave. And after we have this depolarization, then we're going to have atrial contraction. And atrial contraction is going to happen right here in this PQ segment. Okay, so we have atrial depolarization, that's the electricity, and then we have the shock, or the actual contraction of those atria. At this point, now that blood has moved from the atria into the ventricles. All right, and we're going to get into what systole and diastole are, but contraction is basically systole. Now, the electrical impulse has come to the AV node now. Now we're here. And then we know that it goes through the AV bundle into these bundle branches. And now we're going to contract the ventricles. So this spike process is the depolarization of the ventricles. So now this is happening at the ventricle level. And so the impulse will happen there next. And this QT interval from here to here is the duration of that depolarization. And then simultaneously, what's happening in the atria, as this is happening in the ventricles, what's happening in the atria is that these potassium ions are moving out to try and attempt to balance that charge again. And that's called repolarization. So the depolarization of the atria, or excuse me, the depolarization of the ventricles is happening at the same time that the atria are repolarizing to attempt to do another contraction, so that these contractions can just follow each other. Boom, 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 boom. Okay. Now, atrial repolarization. So here's ventricular depolarization. That's what the QRS is. So P is going to be atrial depolarization. QRS is going to be ventricular depolarization. And then the T wave is going to be ventricular repolarization. Now, what are we not accounting for here? We have not accounted for atrial repolarization. Atrial repolarization happens here during that QRS complex, but that QRS is such a big electrical capture that it's blocking our spike for atrial repolarization. Okay, so that happens here during the QRS, but this QRS is so big, this depolarization is so massive that it's blocking any type of spike that we would be able to see for atrial repolarization. So repolarization, potassium is going to move outside the cell to attempt to balance those charges. And then we become more negative inside the cell again, right? So during this T wave is where ventricular repolarization happens. So now at this point, the atria are ready to contract again because they have repolarized, they repolarized here. So the atria do have the potential to contract again, but they won't quite yet. This is going to be the spike in ventricular depolarization. So that's going to be in the ventricular cells of the myocardium, the potassium's moving outside the cell. That's during the T wave. And then notice how we have nothing happening here. Both atria and ventricle are kind of at a rest segment in which they cannot be depolarized or repolarized again quite yet. Now, the atria technically could be, but the atria depend upon the ventricles and the ventricles depend upon the atria. And so if the atria were to fire again too early before the ventricles repolarized, now we have a problem, because if you have contraction of a chamber too soon, you risk the volume of blood being too small in that chamber. Because remember that all of that blood coming into the right atrium is coming from the superior and inferior vena cava and filling this. And we need this chamber to fill completely before it passes into the right ventricle. If this were to contract too soon to where it's maybe only half full, now you have only passed half of the appropriate amount of blood into circulation, and eventually that same volume is going to end up over here in the left ventricle. And if we pump out half of the volume that we normally should out to the rest of the body, our body tissues are not going to get enough oxygen. So it's really, really important that this filling and contraction happens in such a rhythm that the correct volume of blood is also being pumped at the same time. We're going to get into that more in lecture 3, but this is going to be just the electrical activity where we're focusing a lot on this idea of depolarization and repolarization. Oh, and then just to kind of go back to this ST segment is going to be ventricular squeezing or contracting. So just to kind of reiterate, this P wave is when atrial depolarization happens. So sodium's moving in across the membrane. This section right here, this PR is going to be where the atria are going to contract, do their contraction. So the electrical impulse happens first, then the action potential happens, and that's the actual contracting of the atria. So now blood is moved from atria to ventricles. Then what's going to happen is as those ventricles are filling, this QRS is denoted by the depolarization of the ventricles. So in the ventricular cells, the sodium's moving in. And then as that's occurring, repolarization of the atria is happening. So in the atrial cells, potassium's moving out during repolarization. Then during this ST segment here, we have ventricular contraction. So it's depolarized, and then we have the squeezing of the ventricles or the contraction. And now blood is going to move out to the lungs or to the whole body, depending on which ventricle you're in. And then those cells are going to repolarize, in which potassium moves out to try and attempt to balance that. During this refractory period, now we have that sodium potassium pump coming in to move those ions back to their respective sides so that they can fire again. Okay. This picture just kind of goes over this in more detail. So here's your SA node. That's just showing depolarization from that SA node, depolarizing all of the cells that make up the atrial walls. That depolarization is denoted by the P wave. Then those atria are going to contract here. So that's going to be this kind of flat line right here where atrial depolarization is complete, and you can see them kind of squeezing here. So now the blood's going to move into each ventricle. And then here's the AV node. It would be here. That AV node is now going to transmit that impulse down the bundle branches. That's going to be the QR. And then at the S and then the T segment here, we have ventricular squeezing. And so now the blood is going through the pulmonary trunk as well as the aorta. And then the T wave would be kind of the reset or repolarization of the ventricles. And then here was the repolarization of the atria, just masked by that QRS complex. And then this little flat line here is going to be all repolarization is complete. And then the heart is just going to rest for just a split second, and then it can begin beating its next beat. That's from a different textbook. These pictures are from your textbook. It's basically going through the same thing. If you find this in your textbook, just redo the captions, but it's essentially going through the same type of process. Okay, so EKG, that is the heart's ability to conduct impulses. That is what it's measuring. How well is that impulse traveling through all of the cells of the heart wall in order to make them contract? Now that PQ interval was where the atria are contracting or depolarizing, and that indicates the time it takes to get from the SA node to the AV node or across the atria, and then to stimulate the ventricles. Now, if you have prolonged PQ, or it takes longer from that impulse to get from the SA node to the AV node, maybe there's something wrong with those cells in which that impulse is traveling through. In this case, we maybe ischemia or blocked blood flow. Another thing to kind of keep in mind, that QRS complex basically denotes how long it takes for the impulse to spread throughout the ventricles. Let's say that it takes a lot longer to happen. Well, if that depolarization through the ventricle takes longer to happen, okay, maybe we have something wrong with conductivity in these bundle branches, right? So if it takes a really long time for this impulse to get from this AV bundle to all these Purkinje fibers, well, maybe there's something interrupting these bundles. And something that I should note on the EKG is that these, basically the y-axis is measuring voltage, the x-axis is time. And so this is a wide QRS compared to normal, which would be very narrow like this. So this is a wider QRS, indicating that it's taking longer for those ventricles to depolarize. It's taking longer for that impulse to tell the ventricles to contract. Clinical correlation, here's one. So fibrillation, what is fibrillation? So that just means that we're having rapid depolarizations. Now remember, a little while ago, I said that depolarization cannot happen too fast because we need those chambers to simultaneously fill with the correct volume of blood. And so if this depolarization happens too fast, we're not going to have the correct volume of blood. We're going to have a much less volume of blood being passed through circulation of the heart. And normal beats per minute would be about like 60 to 70, 80. Fibrillation is 400 to 650 a minute, which is a lot. So that is the number of contractions that's happening. So basically a fibrillation is just like this quivering rather than squeeze, done, squeeze, done. It's more of like a fibrillation like this. It can happen in either the ventricles or the atria. Very different pathologies here. If it's happening in the ventricles to where the ventricles are quivering and not contracting appropriately, remember that those ventricles are pumping blood to very important places. They're pumping blood to the lungs to pick up oxygen and to the body to deliver oxygen. And if we don't have the correct volume of blood going to either of those areas, our oxygen level is going to be compromised throughout the body, right? And so what that looks like on EKG is basically waves, just like this. It almost looks sawtooth-like. And you can imagine that our depolarization normally looks like this QRS, right? But now our QRS are very, very abnormal, no rhyme or reason to any of these waves here. And that is a deadly rhythm. That is something that they would shock. So that's when they put the pads on your chest and they release a shock to the heart to try and reset it electrically. Atrial fibrillation would be if the atria are doing this kind of fibrillating. That one is not necessarily deadly. It's actually pretty common in elderly populations. It does need treated because, and I'll tell you why in a second. But basically what we see are a fibrillation of P waves. So remember that the P wave here is, right here is denoted by atrial depolarization. So what you tend to see is a lot of little fibrillating P waves. Now the QRS will still be present. It may be smaller, like a smaller magnitude, but you'll have a lot of these little waves prior to the QRS rather than just one P wave. So ventricular stimulation is disrupted, but the ventricles are still filling, maybe not to full completion, but they are filling. Now, high risk of blood clots in this disease, and it's very common in the elderly population. And so basically the atria are fibrillating, atria pass blood into the ventricles, but maybe they're not passing the blood completely into the ventricles, and some blood might just be sitting there. All right, so that's atrial fibrillation. That one, there's lots of different treatments, just depending on how long you have it and how severe it is. Maybe just medication. They had different procedures now that they can do to fix that one. VFib, that one needs shocked. Other cardiac arrhythmias, something called a heart block. So if you've ever heard of a bundle branch block, right or left, that is basically when any part of the conduction system fails. But if we call it a bundle branch block, we're talking about that right bundle in the left bundle. If we need a refresh, that would be here or here. Would be a bundle branch block. But if we have a heart block anywhere, it could be here, it could be here, it could be here, it could be here. Okay, it could be anywhere. But bundle branch blocks specifically are going to be in these bundles. And so, for example, if we have a bundle branch block and we have a problem conducting from the AV bundle to the ventricles, maybe there is a problem with the AV bundle branches. And that is going to not conduct as many impulses quickly enough into the ventricles. So maybe the SA node is firing appropriately, but at the AV node, now something is disrupting that impulse traveling from the AV node down the bundle branches. And that can severely slow down heart rate and cause bradycardia. If you have a total heart block, that is also something that is a medical emergency. A heart rate of 20 to 40 is not good. And you can imagine that if your heart rate is slower, your blood is not pumping blood often enough, oxygenated blood or deoxygenated, but it's not pumping blood often enough to reach your tissues. And the longer the tissues go without oxygen, the more at risk they are for tissue death. And the last, oh, and here's what that's just looking like. So here's P wave. We don't have a QRS or T. Here's another P wave. We don't have a QRS or T. So this is showing us that the SA node is firing, but our ventricles are not. They're only firing about like once for every 1, 2, 3, 4 SA node fires. The ventricles are only firing one time. Something that all of you have probably experienced before is something called palpitations. There's different types of palpitations, but one very common type of palpitation is called a premature ventricular contraction, or PVC. And that is basically just the ventricles firing without being told to. And in this case, you'll have something that looks like this, which is kind of looks like a QRS complex without a P wave before it. So there's no P wave before it, QRS. It's inverted just because of the lead on the EKG. I'll get into that more here in just a little bit. Basically, we're missing a P wave right before that QRS. The QRS is inverted or upside down. That can be caused by a lot of things: stress, lack of sleep, caffeine, nicotine, if you're a smoker. All of those things can cause these PVCs to happen, and they're just little like palpitations in your heart. You've probably felt them before. They are normal up until a certain point, but if this happens very prolonged, then you can actually cause a lot of damage to your heart. I guess I don't have it in this slide, but reason why this would be inverted for a PVC, you do have an inverted QRS during a PVC. Some waves on an EKG are inverted depending on what type of EKG you're doing. So I do just want to make this note that there are different types of EKGs that you can do. You can do one with 5 leads, which is 5 stickers on the chest, or you can do one with 12. And the 12 lead EKG just looks at the heart from lots of different directions: inferior, superior, lateral, right, left, all over. And so in the EKGs, sometimes you'll see the waves not look like this normal sinus, but physicians are still looking for this PQRST when they're looking at those 12 leads. In your case study this week, I provide you an example of a 12 lead EKG. This would be a good strip for like a 5 lead. This one here, normal sinus, you're going to see this in different formats for a 12 lead EKG. I'm not going to go into reading 12 lead EKGs. They can get pretty complex. Some of you might already know if you're nursing, but just know that some waves may be inverted or look a little bit different than this normal sinus in 12 lead EKGs. So keep an eye on that for your case study. In the next lecture, I'm going to get into talking about what's going on mechanically while this electrical stuff is going on.